Good morning, everyone. Welcome to this exciting webinar on polycystic ovarian syndrome. My name's Lesley Regan. I'm the chair of Wellbeing of Women, and I'm really looking forward to speaking to our two lovely panelists, Dr. Bassel Wattar, who is an expert in this subject, and Rajni Singh, who has lived experience. So if we to put this into context, I wonder if somebody can turn off the background noise. Perfect. Thank you. Thank you. So sorry about that. So I want to, as a bit of background, just to set the scene, why are we talking about PCOS, its treatment, its diagnosis and beyond? Because we know that this disorder affects millions of women worldwide, and it's one of the most common, yet frequently very misunderstood hormonal disorders. So during this webinar, we're going to be doing a deep dive into what PCOS is, what the symptoms are, the latest insights into its causes and how it can be managed medically, and how women can impact symptoms through changes in their lifestyle, in what the food they eat, in the exercise they take. So whether you're here in the audience today because you want to learn more about your own health, or you want to support someone you love and care about, or expand your professional knowledge, you're definitely in the right place. So Bassel Wattar is an obstetrician and gynaecologist. He specialises in fertility and polycystic ovarian syndrome. And as I said, Rajni Singh has some lived experience of this, but she's also a very important healthy lifestyle influencer. And so what we're going to do is go to them both, and I will make the questions as easy as possible, and then we will welcome questions from the audience. Please, audience, remember that this will be recorded, and that if we can't get to all of your questions during the seminar or the webinar today, we will attempt to answer them. If you leave them in the chat, put them in the chat, please, so that the team can help me go through them. And don't worry, tomorrow you will get a link to the webinar. And that's the great thing about these webinars. If you register for them, you will then be able to get all of the information and benefit from these experts in their different ways, giving us their inside knowledge. So we're going to talk about a whole host of things. So prepare yourselves, Bassel and Rajni, because this is going to be hard work for the next 55 minutes. We're going to talk about the difficulty in diagnosing and treating polycystic ovaries, some of these really common misdiagnoses, how polycystic ovary syndrome, when I was a medical student, was just a problem that affected fertility and gave you irregular periods. And now we recognize it's a condition which has impacts on the whole of the body and has impacts on women's health in their later life when they are post-reproductive. We're then going to talk about ways to manage symptoms, and we're going to talk about the emotional and the physical toll of PCOS. So you will be aware, I think, many of the audience members who may be interested in this or know someone in their family who's got these problems, that this does have not just emotional and physical tolls that we all talk about, but also quite serious mental health issues as well, particularly when women feel that they're not being listened to or they've been dismissed. And one of the things that the audience, I think, has got used to now is that the reason I applied to be the Women's Health Ambassador for the government is because in the Women's Health Strategy, what we identified was that over 80% of 100,000 women who responded to the public consultation said, I have been dismissed or disregarded or gaslighted by healthcare professionals. So I think that this webinar is going to give us lots of information. We've got lots of time to answer your questions, so please start putting them into the chat. So I've told you all about me. Now, Rajni, if I can turn to you. Rajni Singh is a nutritionist. She's an online fitness coach. I think I need to get your number. And an advocate for women's health who began her transformative journey in her 40s. And despite facing challenges like polycystic ovaries and osteopenia, all sorts of problems with her discs and vertigo and anxiety and depression, she embraced all sorts of issues like weight training, bodybuilding, and calisthenics, and you'll have to explain to our audience what that means, proving that age is absolutely no barrier whatsoever to developing strength and wellness. So she was a former Miss Great Britain, a runner-up. She's a co-author, a speaker, and most importantly, I think she's a mother of two. I hope one of them is a daughter, so you can pass on all your fantastic knowledge to her. And she's going to be helping us to empower you in the audience to prioritize your well-being by simplifying nutrition and fitness. And she's also, not surprisingly, been featured in Holo magazine for her efforts. Now, Bassel is one of my breed. He's an obstetrician and gynecologist. He's also the professor of reproductive medicine and a consultant obstetrician and gynecologist at the Beginnings Assisted Conception Unit. What a charming title, Beginnings. I really like that. At Epsom and St Helier University Hospitals in London. And he's got a particular interest in the diagnosis and management of this problem and other endocrine disorders as well. So he's interested as well in focusing on offering women holistic care, by which I mean not just focusing on the menstrual problems or the reproductive issues, but actually looking at them as a woman right across the life course and in all sorts of other organs apart from the reproductive ones. So we're very much looking forward to hearing what he's got to say and benefiting from the wealth of experience he has. He's obviously done a lot of collaborative work with women's health charities like with Wellbeing of Women, and we're thrilled to have him here as one of our experts, and produced some very impactful research as well about the real health needs of women and their families. So there we are, that's how we start off. So tell me, Bassel, what do you think is the most important thing that women in our audience today, and we've got a lot of people, 239 participants registered at the moment, no, 241, it's going up as we speak. And we'll get many more. And of course, we get lots of people who've registered, but won't maybe able to make it, because everybody knows now that if you register, you get the video or the tape the next day. So tell us what it is that you think has been so difficult in diagnosing and treating polycystic ovary syndrome, because it's a very common problem. We think about 1 in 10 women may suffer from this, don't we? Over to you.
Indeed. Thank you very much, Professor Regan, for the lovely introduction, and for the Wellbeing of Women for organizing this webinar and shining light on this very important and common health condition affecting, as you rightly said, thousands of women worldwide. I think it's been a struggle with PCOS for many, many years, primarily reaching an accurate diagnosis. A lot of women, like you rightly said, feel dismissed and gaslighted, and said that they come to their gynecologist or dermatologist or endocrinologist with one of the symptoms of PCOS, yet no one takes a step back and look at a woman as a person and offer a holistic assessment of all her symptoms and how this could be a differential diagnosis to PCOS. So what we've been advocating, and I know you've been championing Women's Health Hub, is really to have PCOS dedicated clinics that are multidisciplinary, where there is not just perhaps a gynecologist or endocrine gynecologist like me, but also an endocrinologist, dermatologist, and other disciplines that can help us summon this, multidisciplinary care for women. But most importantly is knowledge. I tell all my patients, knowledge is power. So if you feel you have the symptoms of PCOS, please educate yourself. There's a lot of resources from Wellbeing of Women, from PCOS Charity, about what questions to go and ask your doctor and how to really present your story, because that will speed up you reaching a diagnosis and accessing rightly treatment. PCOS is a chronic life condition, but if it managed early on with early intervention, you can pretty much offset most of the symptoms. So many women will enjoy a very healthy life with very simple intervention, like lifestyle intervention. I'm sure Rajni will tell us a bit more about it. So I think it's knowledge and really achieving the diagnosis very early on, and working collaboratively with your health professionals. We always have high expectations from our GPs, but GPs cannot know everything. But if the patient goes armed with the right questions, we often feel, demanding and want to go to a PCOS specialist, they're far more likely to get their diagnosis faster and access the treatment they need very, very quickly.
Lovely. Well, that's a great start. Now, Rajni, do you want to come in about that? I mean, I think had problems getting diagnosed. What do you think prevented the first healthcare professionals that you went to from identifying that you were a PCO sufferer? Not too harsh, please. Not too harsh.
No.
We're very deaf.
For that, I would have to take you back to 90s, because the first thing I remember as a young girl, I got my first period very late, so I was nearly 15. So that was one of the things that was mentally affecting me, seeing my friends, my older sisters. So for me, PCOS is not just a medical condition, it's how it's shaped how I saw myself for a long period of time. So I got my first period, and then imagine having no periods for another 8, 9 months. And then I remember very clearly, I went up to my mom, and I think it was just the awareness was not there. And maybe it's the stigma of not talking to, a lot about periods at that time. So I went to my mom, and she said, "Oh, it's normal. Don't worry. They will." I clearly remember, and poor her. I don't expect her to be, having that kind of knowledge. So she said, "Don't worry. They will come." Then again, imagine a girl. I was yearning to experience how regular periods looked like. How they feel, because I've never experienced regular periods until the age of 14, when I changed my lifestyle. But up until that, it was always 3 to 4 months. Never knew, when my next period is going to be due. But more than that, I think is the confidence, excessive hair growth, severe acne throughout adulthood, and the anxiety, because I never knew up until now that what was the cause of anxiety, because my anxiety would take a whole toll on physically. I would feel that my heart would sink, but I would never know the reason, because I was a happy child. I've had a really happy childhood, but I would never understand the reason for the anxiety. And then looking around at my sisters, I would like it always made me feel I'm not normal. There is something absolutely wrong with me. So I was not diagnosed till I think I was in my early 20s. That wasn't even a diagnosis. It's just my sister happened to take me to a doctor's. No ultrasound was done. I was put on a pill, and I don't know what. Maybe it was a birth control pill. I really don't know. I'm talking about back in India. So I did like the medication made me feel like very, very depressed. I stopped taking it. And then when I got married, no diagnosis up until that. But I knew back in my head, the anxiety and the stress that in regards to fertility, that if I would ever be able to bear children, because I was not speaking, it was about, you are reluctant to share about these things. Then I spoke to my mom, and she put me on homeopathic medication from India. So my periods, they became regular for a few days, for a few months. And during that phase, I got pregnant. But again, back to the normal. Once I stopped taking the medication, they became irregular. I was diagnosed with PCOS after having 2 children in my late 20s. And still, I remember I had my ultrasound done. My doctor said, "Oh, it's polycystic ovaries." Nothing explained what it really means. And all I was again put on birth control pill. I didn't like it because it really made me very suicidal. That was the depression I had after taking those pills. I don't remember the name of it. I stopped taking it. Then again, no explanation about that, no awareness. And then in early 30s, I had pain in my feet, my toes. Went to the doctor, had my ultrasound, osteopenia. And you would be shocked that my GP said, "Oh, you've got the bones of a 50-year-old." Nothing more explained about osteopenia, why that is happening. It could be related to PCOS. It could be, because I'm losing that bone density. Nothing would make no sense to me. And then again, the toll that it takes on your mental health is just extreme. It was extreme. It had become very, very extreme. Sorry, I can't hear you, Leslie.
So sorry, there was so much noise going outside
Yeah.
in the hospital in the street that I turned off my sound. So excuse if you hear sirens, it's because I'm right opposite casualty here. So I was just saying, thank you so much, Rajni. I'm now going to move over to Dr. Wattar, because I'd like him to explore a few more of those things that you've brought in before we go on to the next things that you came to.
Yeah.
The anxiety, the bad reaction to the irregular periods, and just assuming, oh, well, you've just got to regulate them with the pill. So several questions here. What was it about her diagnosis that was missed? And or her condition that was missed in terms of her symptoms? And also, if women do need to be put onto the pill, and we can talk about why that is important, or if not the pill, some other form of medication to help them with their estrogen levels, and how then they can, if you like, store up problems for later, like the osteopenia, because she was quite young, wasn't she, at 30, to have a 50-year-old bone density. So Bassel, over to you there. There's a lot of questions there, but I know you're up for it.
Thank you very much. And thank you, Rajni, for sharing your story. And, I have to say, it's a story I hear every day in my clinic, and we have to do better to change this narrative. I think it's all, as you rightly said, starts from, and missed opportunity to get the diagnosis right. So when a young lady is starting to have their periods, it's normal for them to be irregular. And they often present to their GP saying, my periods are irregular, or general gynecologist, and they get dismissed. No one really goes to look further. We know that it takes roughly about 8 years from start of period or menarche for periods to become regular again. That doesn't mean that we don't, keep looking and continue good patient care to keep exploring if there is a risk of PCOS. And so we don't have a definition for PCOS in adolescents, unfortunately. There's no diagnostic criteria. It only applies in roughly in adults. So the key message here is to keep working proactively with your GP to review your health and not just get dismissed and drop it. If they continue to be irregular, always go back to further investigation. Now, about 20-something years, we have the Rotterdam criteria, which somewhat revolutionized the diagnosis of PCOS, because before that, it was completely all over the place. There's no agreement about how we diagnose it. And it's a rather simple criteria. You need to have 2 out of 3 symptoms to get diagnosed with PCOS, either irregular or absent periods, or a high levels of testosterone or hirsutism, excessive hair or acne on the skin, or an appearance of polycystic ovary on the ultrasound. Now, this appearance of cyst on the ultrasound is often distracting and confusing. It distracts a lot of health professionals because they see it on the ultrasound. They think, oh, it's by default PCOS. The answer is not. There's many conditions that can contribute to this appearance, the diagnostic features of polycystic ovaries. So again, as we started with saying, we need this holistic vision of a woman. What are her symptoms? What's her health like? How is her health progressing over a long period of time rather than one snapshot of review? And they're very simplistic tests. It takes literally one blood test or one visit to do a blood test, and you can get the diagnosis of, do you really have PCOS, or are you at high risk of having PCOS? And PCOS is a dynamic situation, like Rajni, you said, that sometimes with you lose weight, then your periods will regulate, and you have less of the symptoms of PCOS. So maybe you visit the doctor at that point and become difficult to diagnose it. But then you put on weight, say after childbirth, for example, and that aggravates your PCOS, because PCOS is an endocrine metabolic condition. It really reacts to how the woman's body hormones are in a somewhat of a vicious cycle, and particularly with weight gain has a great role into it. In regards to the pill, a lot of my patients come and say to me, please, my GP told me the pill is the magic solution. I don't want the pill. And we have to listen to women. We have to understand their concerns. The pill works for a lot of PCOS patients, but not for everyone. It's not a one-size-fits-all. We have to move towards individualized and tailored treatment. Now, luckily, we're having a lot of more options in terms of how we help women with PCOS. The sad reality is that in the UK, till this date, we don't even have one single treatment that is licensed for use of PCOS. All the treatments we use them off license from other medications, say metformin, for example, that is generally used. It's a licensed drug for diabetes, but we use it off license in managing PCOS, and it's largely safe. So it's important to consider all the different available options, not just the pill by default. And like Rajni, as a testimony of your experience, the pill is hormones, psychoactive hormones. They have significant effect into your mental health. We know that prolonged exposure to synthetic progestogens or progesterone hormones, they can significantly increase the risk of depression and anxiety that is already heightened in a lady with PCOS. So I think that's the summary of answering these questions.
Thank you. So one of the things I think our audience would benefit from is understanding why it is that people are put onto the contraceptive pill. Because it's not really for contraception, and it's not because we think that every woman's got to have a regular withdrawal bleed on the combined pill, but it's all to do with needing to recognizing that the main pathology, if you like, if you call it a pathology, in polycystic ovaries is that woman doesn't ovulate as frequently. So she's not producing a lot of estrogen. And that, of course, is what led to Rajni developing thin bones, because estrogen is the very best bone builder that anyone has ever invented. It's very, very good. And that's why women who are ovulating regularly and don't have polycystic ovaries tend to have quite good bones until they become menopausal in their 40s or 50s. And then with the reduction of the estrogen, that's when the bones get thinner. So it's really important to understand that don't just dismiss the pill, perhaps try and find one that's going to suit you better, or find another way to improve your estrogen. I mean, I'm going to be asking Rajni in a moment about those homeopathic remedies, because I'm, you know, if they did really work for you, I'm wondering what you're going to say to that. But and perhaps we shouldn't be going down the homeopathy just at the moment, because we haven't tackled all the other things yet. But as you say, there are things to do. The pill, very important adjunct. And just remember, when you're talking about the pill, please don't dismiss them all because one didn't work. You know, pills are a little bit like a sweet shop. There's lots and lots of different colours and shapes. So try and find one that will give you the minimum of symptoms, because it is helpful to make sure your estrogen levels are normalised. And then there's a lot of questions in the chat here, Bassel, about metformin, inositol, all sorts of other things. Give us a feel for the other weapons that you use, or tools, I should say, not weapons, tools that you use when you're trying to find a treatment to help women regulate their periods, ovulate more regularly, so therefore generate their own estrogen again, which is what we were all aiming for. But if they're not, you know, they're not on the pill, what's your next go-to?
Thank you. Great question. So what we know for certain right now is that women with PCOS have blunted metabolism. So their body does not process sugar as efficiently as someone else. And that's why it's so easy to gain weight. It's very, very hard to lose weight. And so they often, a lot of my patients come and say, we feel, you know, it's like we're getting this paternalistic advice, oh, go lose weight and everything will be fine. It doesn't work that way. It's a really tough process, and we have to understand that. And a key cardinal feature of PCOS is this insulin resistance. So the body is resisting to the insulin is secreting there because of hormonal imbalance, because of the lack of cyclicity for women. This is not in all women with PCOS, but a far majority. And so we know that using, with a fair degree of certainty by now, there's a big volume of literature that using metformin and maybe a little bit more certainty on myonisitol, that this can help to reduce this insulin resistance, can help a lady to restore her natural cyclicity, as well as aid weight loss. On its own, it's not going to be a magic pill, and a lot of weight loss will happen, but with other interventions, exercise, dieting, and so on, it can help achieving more weight loss. So metformin and inositol are very good and safe. Again, with inositol, we have some data, not huge data, more research to be done. But I think the big paradigm shift is the GLP-1 agonist, like the Manjaro. Now we need more research in PCOS specifically.
Weight loss drugs to recently come, and there's some questions about that in the chat as well. So what are your thoughts about GLP-1 drugs?
It's early days. I think it's very promising, very exciting is that we have something that can really help women. And the way perhaps they think about it, they're not long-term use, they're a catalyst where a lady can start this radical weight loss and then continue with more normal non-pharmacological interventions. So we don't have long-term data on their safety. We don't have data on how they would behave in pregnancy. For now, they're teratogenic. Someone should not be pregnant on them. They are helpful for someone with, you know, really high BMI. They need to go back down. But I don't like the approach of taking them off or buying them online without medical supervision. In my practice, we prescribe them under strict medical supervision with dietary support to really achieve the desired outcome. They're not simple drugs that could be used at liberty, basically.
And I'm sure someone will ask the question, you know, when you stop taking them, do you immediately ricochet back and put on the weight again? Or is it true that having trained your body to require less, perhaps your stomach shrinks a little bit? I mean, I'm being very simplistic for obvious reasons, that is helpful as well. So, you know, and then we get into the psychology of weight loss, don't we? When I'm talking to women who I need to lose weight for a variety of reasons, and not always about fertility, but about other things too, I often say to them, you know, if you can start to shift it, you're going to feel so proud of yourself. And that often is a real sort of fillip, isn't it, to encourage women to carry on doing it. Although, I mean, sometimes I get myself into terrible trouble when I'm asking women to lose weight, and people get very angry and upset about it. So I try to find ways of explaining that it's not that I don't understand how difficult it is, but that's the bit I can't do for them. So I've got to share with them any tricks I can think of. So what are the other tricks when you're trying to get women to lose weight, Bassel, that you suggest that they try?
Very, very good angle. So I think, like you said, it's about how to think about what is allowed to you and what is not allowed to you. So as a person with PCOS, anything with high sugar intake is the enemy, unfortunately. So someone with PCOS eating a cookie is not like someone who doesn't have PCOS. The impact is really greater. So far we have some data to recommend going on a Mediterranean diet for weight management. We're seeing some data to say intermittent fasting is very successful in women with PCOS. A lot of women are restoring their cyclicity and they're getting pregnant naturally on it. There's some very early data on more aggressive forms of diet, like the counterweight diet or the fluid, basically restriction diet. But we definitely need more research on this front. But I think as a whole, I fully agree, is about your philosophy and your relationship to food. A lot of women feel they are on this roller coaster where they're fasting, for example, but then they get anxious or they have this emotional eating and they go binge on sugar, and that makes the whole PCOS situation much worse. And that's why recommending proper dietetic supports and cognitive behavior as well.
Yes, and people need a lot of support doing this because it can be very, very isolating and very depressing. So Rajni, I've given you a few moments to give some thought. What were these homeopathic medicines that your mum gave you, or were they just fluke that they happened to work?
I don't know, Leslie. There are a lot of homeopathic doctors back home in India, but they're like white, tiny, balls, and I really don't know. But they worked magic. I wish I knew more about that, but I'm afraid no. But they did work magically.
Okay, all right then. Well, I thought you might just give someone a fantastic idea that they could start importing these things, but perhaps it's just as well we haven't gone down that route. So I think we need to talk a little bit about skin now, because so many of the women that I see talk about their acne and how disturbed they are by what's happened to their skin, possibly facial hirsutism or hirsutism on their body. So Rajni, did you have any of those particular problems? And
Oh, yes, absolutely. I was the hairiest I could imagine, and acne, especially during my late 30s, I had really bad cystic acne, and not knowing what was the cause of it. Again, it was, yes, I have heard doctors saying it's hormonal, but nothing more to it. So, and it really knocks your confidence down in the ways you think. You look in the mirror and you don't feel great about yourself. So yes, I was put on eventually. I saw a dermatologist. I was put on Roaccutane, but again, it was the lifestyle changes that made a huge difference. I've never had this clear skin all my life, which I yearned for, and the energy. So again, we will dive into that, but it's the lifestyle changes that I made that really made a huge difference.
so tell us about those lifestyle changes. I think I can feel at the moment that the whole audience has got a pen out and they're writing everything down. So off you go, lifestyle changes
Yeah,
to help you.
yeah. See, I wish I had known that before, but nevertheless, started my transformation in 40s. And the first thing is, especially if you are experiencing PCOS, the stress, the cortisol levels. But before we jump onto that, protein. Our main key here is to up our protein intake, and which has to be for people, those who are not even training, at least 1 gram of their body weight. So if someone is 70 kgs, their 70 grams of protein intake should be on a daily basis. And depending on if people are training more, it can go up to 1.2 to 1.5 gram to 2 grams per their body weight. But the moment I introduced lean protein in my meals. It was like a win-win. It was keeping me fuller for a longer period of time. And it helps, balance your sugar levels, because carbs are not the enemy. I've been there, and I'm pretty sure a lot of audience probably can relate to me that, oh, it's the dairy, or it's the gluten, or it's the something else that causes acne. But in my case, it wasn't the case. I eliminated dairy. I have cut down all the gluten. It didn't work. What worked was everything in portion. So your protein has to be, so balanced plate. So balanced plate means that all your macronutrients, which is your carbs, your fats, your protein, your fiber, it needs to be on point depending on your goals and calories. So making sure there's a lot of vegetables and salad on your side. There's sources of lean protein, which people can Google it. It's just a click away. Making sure your meals are lean and carbs, any form of carbs. It could be white rice, brown rice, from my experience, as long as the portion is in control and we're not consuming naked carbs, because naked carbs is something that really spikes your sugar levels. And of course, eliminating ultra processed food and high carb diet, and also weight training. I had been doing HIIT, high intensity workouts, which only did harm to me, because also realizing that I remember I went for a jog, just a normal jog during lockdown. I came back with hip bursitis, not knowing what the cause was. So again, understanding your body, because you don't need to do what the rest of the world is doing. You got to do what serves you. And especially a woman with PCOS or perimenopausal or menopausal, walking is such a powerful tool. Daily walking, daily steps, daily activities. You don't need to do any high intensity workout unless you love doing it once or twice a week. Normal weight training, structured program, traditional weight training, that's more than enough, because building muscle is key here, because muscle is your insulin sensitive tissue. The leaner your muscle mass is, the better your body uses insulin. So that's where the whole point comes in. It's a lifestyle changes, comes in stages, slow process, but eventually it really boosts your confidence. And now I'm going to talk about the cortisol levels, because my cortisol levels were already so high doing high intensity workouts and consuming high carb diet, and especially Indian diet. There's nothing bad with any diet, honestly. It wasn't the intermittent fasting, it wasn't the any specific diet, just normal having my food, clean meals, but simple food, literally simple food, And so cortisol levels, my stress levels were high. So literally going back to where I'm going to say yoga, body muscle, muscle mind connection, bringing your stress levels down. Because if your cortisol levels are high, doesn't matter what you're doing, it really can hamper your progress. And then again, hydration, sleep is so important. If your hormones are all over the place, your sleep is tremendously so important. So it's just a lifestyle change. Everything comes into the picture.
Okay, so I think it's a very helpful tip. If you weigh 70 kilograms, you need to have 70 grams of protein. But what does that look like? What does 70 grams of protein look like?
If someone,
70 kilograms.
no, it's a good question. It's a very good question. It's a really very good question. Basically, if in your breakfast you can opt for Greek yogurt rather than plain yogurt. So Greek yogurt can give you up to 10 to 14 grams of protein, depending on how much you're consuming. Chicken breast can give you up to 25 to 30 grams of. So basically understanding that on your plate, 1/4 of your plate should be your any source of lean protein, which could be turkey, fish, chicken, or vegetarians could be tofu, low-fat paneer, low-fat cheese. So all these forms, they give you protein. They are the real source of protein. Yes, we can have lentils and quinoa, but they're carb sources. So if your main focus,
25% of your plate must be lean.
so 25%, 1/4 of your plate should really be your protein source. And honestly, that can be a big game changer.
Okay, so if that's 25% is the protein, what are the other quarters of my plate going to do?
Yeah, so one other quarter should be your any source of carbs, and I'm really not a great fan where people try to demonize any specific food or try to say this is a magic food. Any form of carbs, throughout my transformation, it's been 4 years, I've been having pasta, I've been having white rice every single day. You choose what your cultural food is, because as Bassel said, that you need to eat what you like to eat, right? Because your food is your emotions, right? So then the rest of the plate should be your fiber, a lot of vegetables. And again, I'm not going to say any superfood, colorful vegetables, rainbow colors. Try choose different colors of vegetables and fruit in each of your meals. So your breakfast can start with some fruit or having some eggs and vegetables on the side, but colorful, have lots of colors in it. And then again, with your dinner and your lunch, again, 1/4 of your carbs and the rest should be your fiber, which absolutely is going to create a whole volume in your meals. Because what people do is they try to do crash diets, and they literally think eating less is key. No, eating more is key, but making sure you are staying within your calorie allowance, whatever your goal is. So that's super important as well.
Great. So no more beige food. Lots of colour on your plate.
Absolutely.
I'm getting all that
A
now.
lot of spice in.
Very good. Okay. So Bassel, what are your thoughts then about diet? And we've talked about the weight loss drugs and things like that. What have you found have been the most useful tips you've given to the women you're looking after in terms of diet?
The research that we have so far tells us that we should focus not just on the diet, but also on the exercise, and most importantly on the habit building, because as Rajni said, food is a culture, and often in this fast pace, you binge eating and eating snacks or so on, that you don't really count as part of your intake. If you're like me, you walk on the labor ward, there's chocolate everywhere, so you keep nibbling chocolate here and there. That will spark your insulin like tomorrow. So a very, very simple exercise that we tell our patients to start doing is to chart their food. And there are many mobile apps that can calculate your calories nowadays, because you'd be surprised. I think there used to be a BBC program about the secret eater, where you just like, you eat a lot of calories that are mostly sugar of, spike in insulin throughout the day without realizing. And this is particularly bad in a PCOS context. So start charting your food, peer support, and learn how to control emotional eating. A lot of the sugar intake that we have is because sugar can calm down our anxiety, but it makes the whole situation much worse. As I mentioned, similar to what Rajni is saying, Mediterranean diet has some early findings in PCOS, but translating it from other populations seems to be working in avoiding excessive weight. But the key to losing weight is really to reduce these insulin spikes in PCOS. So that's why intermittent fasting seems to have a role into it, as well as more aggressive forms like the keto diet, for example. The ketogenic diet works in reducing these insulin intakes, and that seems to help a lady with PCOS to lose weight a bit more rapidly compared to other formats.
Now, I often get women who come into me and say that they're sure that their androgens have gone wrong. Now, so how frequent is androgenemia, hyperandrogenemia, for women with polycystic ovaries?
Sure. So basically within PCOS, there are 4 phenotypes, or 4 different subtypes. And this is, if you go by the criteria that I mentioned, irregular periods, high androgens, or ultrasound appearance. So high androgens are about 25 to 35% of women with PCOS that really have high androgen. And sometimes high androgens could be sort of mixed with other conditions as well, that can cause excessive androgens, like adrenal problems. So they're not always but what we know is that a lady with PCOS who's often lean and doesn't have a lot of fat but have excessive androgens, they often manifest in their symptoms slightly differently. They're more likely to fail, for example, ovulation induction. They might be more likely to require, for example, IVF. They're more likely perhaps to encounter some problems in pregnancy, like miscarriage. So there is a definite role for these androgens. What we often struggle with in clinical practice, and though we don't always have very reliable ways to measure the androgens and throughout the cycle, or it depends on the assays in the lab. So we don't have very harmonized ways to do it, but there is a clinical assessment, which is, assessing how much is excessive hair and so on. Often the challenge is the majority of my patients come to see me in the clinic, they already removed the hair. So you can't really do a very robust clinical assessment. But there's definitely role to, quantifying if there is a hyperandrogenic element, and how to really work about it, because now luckily we have more options to counter the hyperandrogenemia. We have tablets or pills that are particularly anti-hyperandrogenic, like spironolactone, glutamide, the duostride, that can really help women who are suffering from excessive hirsutism. The main barrier is that they're teratogenic, so someone should not get pregnant if they are on these treatments. But there are different options, as well as the cosmetic options that I'm sure everyone's aware of.
Okay, so what are you going to offer them then if the pill is not suitable, and for many women they don't like it or they don't want to be on it? What are you going to offer them then?
We know that metformin seems to help in reducing that. They can either, there is an option where they go on a contraceptive pill that has an anti-androgenic element on it. If they do not want to be on a contraceptive pill, they can be on one of these androgens that I mentioned. And most importantly, they can be on these in a cyclical fashion. So they don't need to be on them continuously, for example, particularly if they're planning for a pregnancy. So we work with our patients longitudinally so that we can work with them on an intensive period where they can, lose weight, they can work on the anti-androgen, then they have a washout period and they go and start trying for a pregnancy immediately when it's safe and sound for them. Then we continue with them after the pregnancy.
Okay, so I'd like to ask you both a little bit about the longer term implications of polycystic ovary syndrome. And if you can explain to us and the audience how it is that we know now that women who have polycystic ovary syndrome are more likely to have cardiovascular or heart disease problems later on. Now, it's not just about hypertension and lipids and weight, is it? It's to do with some quite complex metabolic issues as well. So Bassel, would you like to start there, and then I'll go over to Rajni because she may have some thoughts and lifestyle ideas as well. Sure. So you do the medicine and she can do the lifestyle.
No, 100%. And this is often, it's a very important element that is often dismissed because most patients will go see the doctor for the acute symptom and lose the focus on the long-term health optimization. And as you rightly said, there is often an increased oxidative stress element in PCOS that is to do with the blunted metabolism. And as we mentioned, there is a metabolic inflexibility, meaning the body does not process sugar as efficiently, and that leads to this chronic state of oxidative stress that works on increasing long-term cardiovascular disease. A common health issue that is dismissed is sleep apnea. So women with PCOS do suffer from higher chance of sleep apnea, where they just wake up at night because they're not breathing very well. And we know that sleep apnea is directly correlated with higher risk of heart disease in the future. So it's very important to get diagnosed on that and to work with your health doctor to eliminate it if at all possible. And as well as the long-term obesity element. And something that is also poorly evaluated is the long-term increased risk of endometrial cancer. And that has to do with the lack of cyclicity, which unfortunately often becomes less relevant for a lady after the age of 40. So they start to focus less on their period and dismiss them, but that increases the risk of endometrial cancer. So again, honing back on the importance of this holistic care to identify all these risk factors and work with the patient collaboratively to reduce these risk factors long term.
Yes. And I think it's important for our audience to understand as well that although we started off talking about Rajni and her thin bones because she wasn't ovulating regularly, the other problem here is that when you're not ovulating regularly, you may not have enough estrogen, but you certainly don't have enough progesterone hormone, which is the hormone that is secreted in the second part of the cycle after ovulation. And that is the one that makes the womb lining calm down and stop becoming precancerous. And one of the things that my gynecology cancer expert colleagues tell me is that there's been a massive increase over the last 5 years of endometrial cancers due to the increase in obesity and raised BMIs, because the estrogen that is stored in the excess body weight is unopposed by sufficient progesterone, so the womb lining builds up. So another reason to try and get your BMI down to normal, but easier said than done. Now, Rajni, some thoughts about how we could go about that as well from you, from the lifestyle side of things.
See, most of the women, especially, I'm going to say that when you are in your late 30s, the main thing that they always say that, the weight gain. And that is because of where our metabolism goes down. So again, going back to, the metabolic disorders, the lifestyle disorders, they are mainly can be managed through your diet, through your daily habits, as Basil said, through just simple things, because I think, unfortunately, we are in that world where everything is trending. So basically, you need to narrow down everything, what serves your goals. And the goal here shouldn't be just to look slimmer or having a smaller waist. It's the overall health. And honestly, as I said, I've never experienced regular periods until age 40 now. My periods are regular, I'm navigating perimenopause, and I feel my best and strongest. How? Simple food, simple exercises. And as I said, when I was diagnosed with osteopenia, To be honest, it affected me so mentally in a sense. I was pushing my body even more because I'm thinking, why? I should have more strength because I'm only in my 30s. And I was doing high intensity workouts, and I really damaged my body in that way. Especially long hours of desk jobs, it really is not good enough. So a bit of mobility exercise, a bit of walking, a bit of mindfulness, because life is already very hectic. It's just the small, compartments. If you start picking boxes, each one at a time, one habit at a time, we can really look after ourselves the way, our body needs it.
Yeah.
I hope I've answered your question.
No, very much so. It's really helpful to understanding about all those things. And as you say, I think we've really got to talk about the value of weight-bearing exercise and
Yes,
also lifting weights and doing
absolutely. It's the key.
because
It's the
that's the exercise that builds up the muscle, and that's what
Absolutely.
and
Because that is what helps speed up your metabolism, because the more lean muscle mass you will have, the more metabolic rate you will build, and the more calories you'll be able to burn, and your body, because the whole point is to really lose that body fat around your abdomen, because that's a visceral fat, that really indicates to you or puts you at a higher risk of having lifestyle disorders or long-term conditions.
and even if we forget about the weight issue, we know as well that weight-bearing
Sorry,
exercise.
I lost you, Leslie.
I said, and even if we forget about
Can you hear me?
yes, even if we forget about the obesity side of things, we know that the weight-bearing exercise and increasing your weightlifting and your muscle mass is one of the most important things to protect women postmenopausally from becoming frail. So,
Absolutely.
my big worry postmenopausally, and I'm very postmenopausal now, is trying to offset my cardiovascular disease and offset my osteoporosis and frailty. And
Yes.
if hopefully offsetting to my dementia right until the end of my life, which is why I'm not going to retire, because I'm sure that you keep active, it's much better for you. So I'd like to finish, I think, well, not finish, we've got about 10 minutes more now, but I'd like to come on now to the mental health side of things, because so often this isn't catered for well, and we don't ask women about this, or girls. And there are quite a few questions or comments in the chat here about how polycystic ovary syndrome made them very depressed, very anxious, really affected their mental well-being, their self-esteem, etc., etc. So, Bassel, what do you see as one of the major complications in your medical role of brain health, if you like, linked to polycystic ovary syndrome?
Certainly. So I think often a very dismissed element is the body image difficulties, because a lot of women feel they have low self-esteem, they have low self-worth, and it often also comes with a lot of psychosexual problem and affects their intimate life and other aspects of their everyday family life. And these are very poorly explored in clinical settings, particularly in primary health. And I'm not, I know all my GP colleagues try to do their best within the limitation of the available resources. But I do think there is a need for a bit more screening and signposting for help on that front. And in my clinic, while we are in secondary care and we are also limited on resources, we have a questionnaire we ask about the depression, anxiety, and body image issues. And if someone is flagged as high, we highlight this to the GP. Unfortunately, we don't have the service to summon help within the NHS, something for us to work on. So I think it's just shining a light on these issues and not keeping them buried underneath the surface, because then they can rapidly increase and cause a lady with PCOS to go into this really bad vicious cycle, as we explained, where the lifestyle goes wrong, all the health habits are very wrong, and they just feel like they just can't catch a break. So it has to be a very important element of their holistic care.
Yes. Thank you. And Rajni, what are your thoughts about the mental health toll and the problem?
Oh my God, it's very close to my heart, Leslie, because I have suffered with mental health issues, depression, anxiety for a long period of time, and not knowing the cause of it. So now I'm in so much better place because I understand my needs, my body, because PCOS, I understood that before I was letting PCOS define me, but now I've embraced it. I've understood the tools, I manage it well, and I live with it now. But not letting it define me. But yes, I have myself have actually been there. And also that's why I'm saying that it's super, super important to bring your cortisol levels, to bring them down, because that could be one of the causes that can really have a knock-on effect on your overall, life.
Now, there's one or two questions, and some of the ladies who are on the call are saying that they're there because they've got lived experience of PCOS, and they're also working in women's health and they're researching it. Which reminds me to say that, yes, it is very much a part, or very much mentioned in the Women's Health Strategy document, which I'm trying to help the government implement. And there's also a new all-party parliamentary group bringing attention to polycystic ovary syndrome. And again, wearing my ambassador hat, I know now that NICE, the National Institute for Clinical Excellence, are rethinking or revising the original guideline on polycystic ovary syndrome. And sensibly, I think that they're going to use the Australian, the one that came out of Monash a couple of years ago, and they're going to adapt that. Because, of course, it's very easy to say, oh, we'll write our own guideline. But, sometimes, well, I think I've got to that age in my life and my career where I'm fed up of writing guidelines and reports. We need to change things, and we just get in and do stuff. So I think wherever we can, if we can utilise or adapt things that have already been done on this, and then tweak it for a UK, audience or healthcare, that will be really good. So watch that space. NICE takes a little while to come on, and also thank you to the lady on the platform that put all this in, and also pointing us to charities that do polycystic ovaries. Well, as you can see, Wellbeing of Women are very interested in polycystic ovary syndrome, with rarely a day that we don't get queries about it. And Verity, the charity, which is also, there's lots of different groups who are working with this. And I did attend the inaugural meeting of this all-party parliamentary group, and I was encouraged that instead of sort of just wanting to talk about polycystic ovaries, they were very receptive to my suggestion as the ambassador that perhaps what we need to think about is that this is on the spectrum of menstrual problems and fertility problems. So, and if we look at it as a continuum, then I think the problems in later life that Bassel has talked about so elegantly will be much easier for women to understand and try to postpone or prevent from happening. So, some questions about why is it that we don't have more treatments apart from the pill, because all of us have come back to saying the pill is a mainstay. Now, there's one or two people in our audience who don't like that at all, which I entirely respect, and they probably had a horrible time on it. I didn't like it much myself, but there we go. But the thing is, what we've got to do, what are the other treatments? Now, somebody's mentioned Zoladex, and then of course there's the new Ryco, isn't there? The new drug that's come out that gives you some of the LHRH analog down regulation to try and help the cycle and the postmenstrual dysphoric disorder, and then adds back some estrogen, like a form of HRT, to make sure that that's not a problem. Have you got thoughts about that? Are there new ideas that we can explore?
Yes, certainly. And I really echo the sentiment that we need to get on and change. So I'm sharing with everyone that next week we are hosting a educational course with Verity Charity for all health professionals in the UK. You really want to move on from writing guidelines to really educate health professionals to change the status quo for PCOS. We had challenges with research in PCOS because for many years it was silo thinking, that gynecologists are doing research alone. Yeah. Endocrinologists are doing it alone. So I think since this international guideline, we're doing more collaborative work, and certainly in the UK, we have a more unanimous sort of joint of researchers working together on it. And Rieco is, or these oral GnRH techniques, fantastic addition to our sort of repertoire of tools that we can use. It's not been tested in PCOS. We are doing a pilot study on it right now. I think it will offer a lot of alternative hopes to women with PCOS, that maybe there's another new drug that can be used. But definitely need a bit more sort of longitudinal thinking about how can we implement intervention that helps women for the long term rather than with a snapshot sort of immediate symptom.
Lovely, thank you. And I see that Sharon Manship was the lady who has been doing research work, having been having lived experience of it, and lots of people are wanting to know about her research. So Sharon, we'll be in touch with you if we may subsequently, and perhaps we'll be able to invite you to talk about your research and thoughts in another webinar, because this has obviously been a very successful topic. Many thank yous in the chat about how delighted women are to have a whole webinar devoted to this. And we like to do that at Wellbeing of Women, picking a topic, possibly not a mainstream topic even, although this of course is, and then giving it a whole hour's worth of thought, but particularly inviting experts from different different specialties and things to help us do. So there's a question here about naked carbs. Just in one quick sentence, Rajni, what's a naked carb?
Naked carbs, any source of carbs, like having rice on its own, or having oats on its own. Balance it with protein on the side, some good fats on the side, and maybe fruit or whatever source of fruit. So naked carbs, it spikes your sugar levels. So when they're combined with fats and protein, or either of them, they actually slows down the process of the sugar going into your bloodstream. So that's the whole point, how to stabilize your blood sugar levels. Always have a balanced meal rather than just going for naked carbs. I know they taste well, but that's what
So we're saying not so much that they're naked, i.e. not dressed, but then they shouldn't be eaten alone.
Yes.
All right, then I think some people were wondering whether that meant you mustn't put sauce on them, which you probably shouldn't anyway. But but no.
You can have, honestly, to be honest, you can have a drizzle of sauce, but when they're combined with other macronutrients, which is the proteins and fats, that's where the true magic comes.
Okay. Now, one last question for Bassel, well, rather before we finish. The question here about the link between polycystic ovaries and underactive thyroid, so hypothyroidism, and chronic fatigue. What are your thoughts about that?
Thank you. Yes, we think there is a small subset of patients with PCOS where they could be an autoimmune element into their condition. And that can often manifest with hypothyroid, for example, which can have an autoimmune element into it, as well as other conditions like diabetes or adrenal issues or ehlers issues, for example, or it's more genetic. So there are different variations of that. But we also pick in some association with endometriosis, for example. We still need to do more understanding about how that can, what is the link between PCOS and endometriosis. So certainly there is a small subset of autoimmune element in PCOS, but we don't have a lot of research about it. There's more and more advances in the epigenetic of PCOS, which hopefully will help us to understand more about the different subgroups within this condition.
Yeah, agreed. And I was interested that Max Hyam, who's put in a lot of things into the chat, but I think it's really interesting. She's saying that the best person to treat your condition is yourself. You know more than any doctor out there. And I couldn't agree with you more.
Absolutely.
One of the reasons I took on this ambassador role is my mission before I finally hang up my shoes or whatever I'm going to hang up, is to get women to be their own advocates, because they're very powerful. And, why would we not want 51% of the population and the people, those individuals that make 80% of all household medical, plans? Why would we not want them to be really well informed so that they can actually be part of the solution? And then, as I always say to everybody at Wellbeing, the wonderful thing about women, to my certain knowledge in all the years I've worked with them, is that when you tell women about things that can help them, not only do they usually do it, but they don't keep it to themselves. They share it with everybody else. And as I said, 80% of health decisions in families are made by the women or the matriarchs at the top of the family tree. So with that, it's now 12:31, and very soon the team will be sending me WhatsApps to say, now stop it, you've got to stop talking about the webinar's finished. So I'm going to say thank you again to Rajni for all of your tips and for coming to join us today and giving us such positive thoughts about things. And thank you to Bassel for all of your help and advice and for answering all of these questions so helpfully. And as I say to the audience, thank you for being here. Thank you for your enthusiasm. There are, no, God, I've got 99 more new messages. I can't get through all of those. We will see what we can do by linking some of them together. And I hope that tomorrow, if you some things you feel you've missed, that you can go and source the video that will be sent to you on a link tomorrow, and then you've got it as a weapon, if you like, for the future and for sharing with others. So thank you, Bassel, thank you, Rajni, and thank you to the Wellbeing of Women team for this super seminar. And I look forward to welcoming you to the next one, which will be next month. Bye-bye.
Thank
Thank you very much.
Thank you for
Bye-bye.
having. Thank you. Bye.